neglect or misdiagnosed, and it is usually underdiagnosed also. So delirium is very common, not only in palliative care, but also in any other specialties. But the only thing is, it is not diagnosed properly. So delirium, it occurs in many patients, and it is more common towards the last stage during the terminal disease of the patient. So today's session will be taken by Dr. Charu Singh. So Dr. Charu, friend as well as my colleague, and both of us has worked in Amrita Institute of Palliative, Amrita Institute of Medical Sciences, Kochi, and she was working as the professor of palliative medicine at Amrita, Kochi, but now she has shifted to Delhi and planning to join the new Amrita Institute of Medical Sciences, which is going to be started at Delhi. So Dr. Charu has, I think she has about more than 15 years of experience in palliative care. But basically, she was an anesthesiologist. But later, she turned out to be a palliative care physician, and she is continuing her journey as a palliative care physician now. So, welcome, Charu, and it's over to you.
Thank you, Sunil. It's nice to see you after a long time. We've had some good times together when we were working in Amrita. So glad to be a part today. So as Sunil has said that delirium is a symptom which is very common and is not isolated or restricted to either palliative care or oncology, or as most commonly people think, in the intensive care unit. So these are the common places where we usually pick them up, but there are various stages of delirium. So hopefully I will be able to convey some things to you today. I'll share my presentation first. Can I share screen?
Yes, doctor, you can share.
Okay. All right. You can see this and hear me properly.
Doctor,
you can see my screen?
Yes, we can see your screen. Your voice is a little bit breaking. Can I off your video and see?
Yeah, sure.
Can you start, ma'am? We will.
All right. Okay. So I believe this is a group of 35 participants, out of whom there are about 30 doctors. So has anyone experienced a patient who has delirium, and can you describe? You can put it in the chat box. Has anyone seen a patient of delirium? Do you know what delirium looks like? I don't think I will be able to see the chat, so
yeah,
maybe.
Charu, Dr. Geetika says she had a relative with delirium.
Okay. And what were the things that he...
So Rajit says many patients. Edward says yes. There are many responses.
Okay.
She was disoriented.
Disoriented, that's one. Then anything else? Any other sign or symptom of... How do you identify that someone is delirious?
Confused.
Restlessness. Yes,
Keep
these are some of...
Yeah.
Fluctuating. That's a very important point that has been mentioned. Thank you so much. So I will go ahead with this. Now I cannot move my Okay, so I think Sunil is already familiar with this. So this is a case scenario which is very common. A 70-year-old lady who had chronic renal failure. She fell down, fracture of neck of femur after the fall. So she's elderly, so osteoporotic with CRF, the osteoporosis is worse. And fracture of neck of femur is very common in the elderly, as we all know. So this lady was hospitalized. She was dialyzed, and the doctor said that they will have to put an implant, replace the hip. So she was taken to the theater and post-surgery shifted to the ICU. And the doctor said that her bones were so weak that they could not put the implant. This is a real case. So when the family saw her when she was in the ICU immediately after the surgery and coming out of anesthesia, they found that she could not recognize anybody and was very aggressive and abusive. And she accused her husband of 50 years, like she's 70. So yeah, those days probably marriage of at 20 was not uncommon. So she accused her husband of 50 years for plotting to kill her. And then she died after 2 days in the ICU. So what is the impact? Why are we discussing delirium today? Why is it important for all of us, for the healthcare professionals, for patients, for families? As far as patients are concerned, because one of you had said that delirium is fluctuating. So a person may have intermittent memory, that their behavior was not normal. It was abnormal. And it might be very embarrassing for them, or they might be feeling that they're losing control over the situation. It's a psychological thing. Or, apart from the physical illness, they're also developing a mental illness. And hallucinations, I'm just going to go ahead and tell you that these are things that you may perceive. You can hear someone, you can see someone, and that can appear very frightening to a patient. And also literature has told us that when a person, especially a cancer patient, presents with delirium, it is a predictor of approaching death. It means that the person, you can start counting their lifespan in weeks to months rather than months to years. So delirium is a predictor of death, and this is also important for the family members then. So, here in this situation, the family was confused. They were angry. Some of them were feeling guilty because not all could be there to look after her. The people were doubting what is wrong. Have the doctors given us some medicine? There was this fear that our loved one has this physical illness and now she's going mad. And there was no possibility of any meaningful conversation with the patient. Not because the patient was in the ICU, but because the patient was disoriented, did not recognize anybody. And like I said, the predictor of death for the family also. Families start realizing that their loved one is going downhill very fast. And for the physician, now it is very difficult to judge what the symptoms may be, because as you know, in palliative care, we deal with symptoms, and symptoms are things which patients tell you what they're feeling. You cannot measure it. What you measure is sign, and what the patient tells you is a symptom. But then how do you judge how much pain the patient is having? Or is the patient finding it difficult to breathe? So to assess the symptom and to manage the symptom becomes a challenge for the physician. Moreover, in this situation, to send a patient back home is very difficult, especially for the family members. How would they manage? And for physicians also, the fact that it is a predictor of mortality. That is an indication for us. So why this is important for physicians is that we need to start preparing the family members as to what is happening or what to expect in the next coming few days. Beyond this, if there is more service utilization, as in the patient has to be admitted because they cannot be sent home. Perhaps there has to be a nurse who has to be dedicated to looking after this patient because this lady is aggressive. So our hospital services are utilized more for one patient because if you are unable to identify and control delirium. Incidentally, I think some of my colleagues would know, this particular lady was my grandmother. All right. So, so this is first-hand experience that I'm telling you about. So, but why should we spend so much of time on delirium? So we need to see how common it is. I mean, if you just look at it, end of life, 83% of people will have delirium, and cancer patients will have delirium in their journey of cancer. At least 85% of the patients will have delirium during their journey of cancer. So it is something very common. But if I ask you, will you agree with these numbers? Can you just put yes or no in the chat box? Do you agree these numbers are correct? It's an old publication. Is it? Do you think this is correct? This is overrated? Overestimate?
One response from, Priyank, Dr. Ramakrishnan, yes.
He says that it is overestimated. It is not that common. Okay, then.
Somebody, Dr. Rashmi says, I haven't seen this many in my practice.
Okay.
Dr. Neelima says, when you say 83% at the end of life, do you mean 83% of all people, irrespective of comorbidities?
I'm talking, I didn't get that question very well. But when I say 83% of people who are dying will have delirium, that's what I mean. So whether they're dying of cancer, whether they're dying of COPD, whether they're dying of chronic renal failure, whatever the diagnosis, if they are end of life, 83% of the patients would tend to have delirium. Now, why this disparity between your perception of the frequency or prevalence of delirium and my perception of delirium? Number one, it is very difficult to diagnose and a difficult to treat symptom in oncology and terminal. So we need to know more about this. So how do we identify delirium? This is the question that I had started off with, and you had mentioned in the chat that there is an altered level of consciousness, and which is also fluctuating. Sometimes the patient will be alert and sometimes not. Many times you go on rounds and the patient is completely oriented and alert, and when you go away, the nurse will call and say that he's talking irrelevant. So, or sometimes you have to ask the family members that does he forget in the middle of a sentence what he's trying to say? And the family will say, yeah, it happens, but it happens only once in a while. So that is the beginning of delirium. It is fluctuating intermittent, the person, what the definition that we are looking at delirium, or from our experience, we find someone is agitated, aggressive, wanting to hit someone or wanting to jump off from somewhere. But delirium does not always present like that. And so when we look at the definition of, and we will go on with the description of delirium, we'll realize that actually, why do we call it 83 and 85%? Because there are various phases of delirium. So apart from the altered level of consciousness, there is an inability to shift or maintain attention. So sometimes you do a test, like you ask them, start with 100 and subtract 7, 93, subtract 7 again, 86, subtract 7 again, things like that. So they are unable to do that sometimes. Disturbance of cognition and perception. Now, cognition is hallucination. They're seeing things, they're hearing people, they're hearing sounds. Many people may say we're seeing someone who has passed away. Perception is you're seeing something, but you don't see that particular thing as what it is. It may you may perceive it to be something else. For example, the commonest thing that I remember when I started practicing palliative care, in our wards, there used to be curtains separating the patients. And many people would say it's snakes hanging from the ceiling. So that is that's a change in perception, a disturbance of perception. There is something, but they perceive it to be something else. And cognition would be, oh, the nurse is coming to kill me. She's coming to give me an injection to kill me. A false thought, right? So, and another very important thing is that delirium invariably is of acute onset and has a tendency to fluctuate. Now, why do I mention acute onset? Can anyone tell me why acute onset? While you're typing out your answers in the chat box, I will move on because we need to have our discussion also. So acute onset, there is always, when a person is delirious, there is always a precipitating cause for delirium. And that is why we say it is acute onset. But why are we specifically mentioning it here? There is a pre-existing medical condition which may precipitate this acute onset here. There are many screening tests for delirium. The one that I have just mentioned to you in my previous slide is the confusion assessment method, which is the one that I use most commonly. But I believe there is a memory delirium assessment scale. This is supposed to come in the next line. So memorial delirium assessment scale. Sorry for the mistake in the slide. So there are tests which you can use as a screening tool till it becomes a habit for you to be able to identify based on a couple of questions, you are able to identify a person is delirious or not. So basically in a person with delirium, everything gets mixed up. They don't know whether it's day or night or where they are and things like that. So now what are the clinical subtypes of delirium? So hyperactive is the one that we see most often, where patients are agitated, aggressive, they have hallucinations. So this is what we normally say is delirium. And that is why you think the percentage of delirium can't be above 80s, right? But there is an element of hypoactive delirium. A person will be sleepy, withdrawn, might be confused. People may think that the patient is sedated with opioids or with benzodiazepines, or he's dying and there's not enough oxygen, and that's why he's sleepy and withdrawn and confused. But this is also delirium. It's a hyperactive delirium. So, and then you have a mixed variant of delirium, where the person moves from agitated to the quiet phase. So if you include the hyperactive and the mixed versions of the clinical subtypes, you would know, then you would understand that the prevalence of delirium is actually quite high. Now, the problem is our differential diagnosis. We did the clinical features, right? We had changes in mood. People may be angry, as my grandmother was. She did not want to see her family, her daughters, her husband. My grandfather was heartbroken when my grandmother refused to meet him. They had come at the time of India's partition. In 1947, they had come to India and they had built their life from scratch. And my grandfather, though very mature and seeing many things, was very badly shaken. He thought that this is what my grandmother thought about him all this time, that he's out to kill her or he's abusive and things like that. So there are subtle changes in mood. There are changes in sleep-wake cycle. A person may sleep throughout the day and then be wakeful throughout the night. These are the earlier signs which we should be able to capture, because they will tell us that the patient might head towards agitated delirium. And if we identify hypoactive delirium and intervene at that point, then the agitation and the aggressiveness is not there. And then the family's trauma of watching the patient in that state is also not there. So loss of memory is common, and it is invariably loss of recent memory. So the person may say, I'm still at home, I'm not in the hospital. This doctor has not seen me before. There might be difficulty in verbal expression. They start saying something, but they forget the words. What were they thinking? I'll give you an example. When you have a common cold, many people take cetirizine and they say it makes me drowsy. You are awake, you have a conversation. Later on, you have no memory of that conversation, or you have a mixed memory of that conversation. Does that happen to any one of you? It happens to me when I take an antispasmodic called cyclopam. I have a very rational conversation, but I have a vague sense of memory of what really happened later on. So we have done difficulty in verbal expression, incoherent thought process. You start talking about something else and then you digress. Inability to concentrate, we have already mentioned this. Right? So these are some of the clinical features which you should be asking for, because the family will not tell you. This has happened very frequently, and I'm sure Dr. Sunil will agree with me that when you go and talk to the family and you ask them, has he been sleeping the whole day? They says, yeah, he was sleeping the whole day. So he was awake the whole night. So now he's sleeping the whole day. So they feel that there is a justification to this, but you have to dig and ask. Then you have to ask whether, does he forget? Is he sleeping, talking in his sleep? Or does he forget while speaking? Does he forget what he was trying to say and loses track? So these are some things which are very subtle and are signs of hyperactive delirium. And if you catch that and start treating, you will prevent the hyperactive delirium. So visual and auditory hallucinations we've discussed. These are perception, this is cognition abnormality, delusion and perception abnormality. So the clock is looking upside down for this man. It might look like a person's face. The curtain might appear as the body of a ghost or someone who has passed away and they have come to take this patient away. So all these are delusions. And there might be either psychomotor agitation or there might be psychomotor retardation. So hyperactive delirium means psychomotor retardation. Their thought processes, their movements, they all become dull and slow. And we might think, like I said, it's end of life, it's medication, it can be, is he depressed? So we have to be very clear in the differential diagnosis, whether is this depression or is this hypoactive delirium. If one clue is given in this slide itself, that in a patient with depression, they will not have a fluctuation in level of consciousness, whereas a person with hypoactive delirium will have altered conscious level in and out, fluctuating type. Is it clear up till now? Any questions coming up? You want to stop me and ask something?
Anybody has any questions till now?
This is a complicated topic, and it takes time for us to learn to pick up this hypoactive delirium. But I think your primer and your you will also get the presentations, and we will be having a discussion. So no questions coming up, Sunil. Shall I move on?
Yeah.
Ma'am, hello. Can
Yeah.
I? Yeah.
Please.
So, hi, ma'am. I wanted to know most of the time, like, we have people dying in our relatives and families. So, most of the times, I saw that, for like 1 or 2 days before their death, they started sleeping more and not talking to anybody and having exactly what you're saying. So was it delirium for them?
It could be delirium for them. It could be delirium for them. They are not telling us, they're not able to speak to us, perhaps. But then this question is actually a little tricky because especially in cancer, when a person is dying, their general body is shutting down, so they will become hypoactive per se. But whether it is delirium or it is not delirium, we will need to use one of the screening tools. We'll need to see whether the drowsiness is fluctuating, or is the person trying to say something which is irrelevant. Once in a while, when you ask them, would you like to eat something? Would you like a sip of water or something like that? They give an irrelevant answer. So it is difficult to say. That is why my third slide said that it is difficult to diagnose whether a person is delirious or not. And if a person is delirious, it's very difficult to diagnose what symptoms they are having. So a person who's delirious, hyperactive delirium, he may not be able to tell you that it's the pain, or it's the IV line or the Riles tube that's coming out of his nose, which is one of the precipitating factors of delirium. So I haven't clearly answered your question, but the thing is, it can be both. Sunil, would you want to add something here to clarify?
Okay, Charu. So any patients who are dying, who has a chronic progressive illness. Usually, some of the symptoms and signs of death are they will be progressively losing their consciousness. They may be withdrawn. They may not talk. Previously, they were talking, but now you may not get any answers. The
Yes.
intake will be reduced. So it
Yes.
may be a sign of dying also. But as Charu told, if there is something that things like irrelevant talking or hallucination, delusion, etc. are there, then we can be sure that it is terminal delirium. So there is an
Thank
entity called terminal delirium. I hope Charu will talk about that in her presentation or later.
Thank you.
Thanks, Charu.
We'll discuss that also. I think Sunil, the clarification was very useful. Yes, people towards the end of life generally tend to become, and I think we also presume that suppose someone is breathless, they don't have enough oxygen in their body, carbon dioxide is not going out. All these can cause dreams, but the person may not be able to tell us that he is dreaming, yet the dreams may be frightening for him. So we sometimes prophylactically add a very small dose of an antipsychotic agent just to prevent that sense of distress that the patient might be feeling but is unable to explain to us. I've probably ended up confusing you even more, but we are going to have our discussion, so we'll see. What do you need to so the high percentage that I mentioned of the prevalence of delirium in end of life and in cancer, how these are the some of the conditions that we get them confused with. Dementia. Now, delirium, if you remember, I had mentioned that it is acute onset. There is a new medical complication that develops which precipitates this delirium. So dementia is slow onset, very gradual deterioration. And changes in sensorium or consciousness occur very late in the stage. It's not like they will be drowsy during the day and awake during the night, so this may still happen. Okay. Then we have anxiety and depression. There is no change in consciousness and there is no change in cognition or perception. They will not be thinking that someone's trying to kill me. That's paranoia, that's psychosis. They need a different kind of help. But they will not presume that the curtain is a snake or something. So anxiety and depression also, people become quieter. So these are differential diagnoses for hypoactive delirium, which is what we miss. And that's why we think that delirium is not as common as we think it is. So psychotic and manic states is where you see the agitated patient, and you have to differentiate it from a person who may have a pre-existing medical psychiatric condition. They may have a pre-existing psychotic condition. So you have to ask the family for history. And that is how you will be able to differentiate whether this is psychosis or this is hyperactive delirium. Then substance abuse and withdrawal. So you will have to take a good drug history about smoking, about benzodiazepine abuse, about opioid abuse, about multiple other drugs that are in the market. I don't know the names of those. You have to take the relevant drug history there to be able to differentiate. I'm sorry. So basically, how does delirium happen? Why does it happen? It's an imbalance of between neurotransmitters acetylcholine and dopamine. And the reason why I've mentioned these two drugs like this is because there are many medications that we use in our patients in palliative care and end of life, which either affect acetylcholine or which affect dopamine. For example, tricyclic antidepressants. They have an anticholinergic effect. They can precipitate delirium, right? Including perinorm. Can anyone suggest any other name? Okay, so you will know anyways, haloperidol has an effect on dopamine, metoclopramide has an effect on dopamine, the morphine, antidepressants, tricyclic antidepressants, they affect acetylcholine. So if the balance gets impaired, that is when you start having delirium. So we need to maintain the balance to prevent or to control the delirium. So which patients are at risk? What are the red flags? Who should we keep an eye out on who is likely to develop delirium? So elderly people who are moved from home to the hospital. If the illness is very severe, like my grandmother, who actually had a fracture of femur, but she had a she had a dialysis, but was in the ICU and became very sick and became very agitated. None of the family members are still able to accept it, even though this is about 20 years old history. So anyone who has pre-existing cognitive impairment, dementia. Here again, I'll tell you, my father-in-law has dementia. And when he gets constipated or when he has a chest infection, he also has COPD, he's 86 years old. So when he has a chest infection, then he starts thinking that the house is a train, right? So people who have a pre-existing psychiatric illness are more likely to develop delirium. People who have had stroke, people who have sensory impairment or overload. That is why we always say when patients are being brought, elderly patients especially are being brought to the hospital, they should be brought with their spectacles and hearing aids. And when we have to give information to the patient or talk to the patient, especially when the patient is oriented some of the time and wants to know questions, we should give them information in small chunks, not a long lecture of 1 hour like I'm going to give to you today. So that your attention span after 20 minutes would disappear. So those are the people who are at risk of developing delirium. And now we look at what precipitates delirium in those kind of patients. Dehydration. That is why we say in end of life, you can simply forget about calories and protein and adding ghee to their food and things like that. Hydration is very important because dehydration can precipitate confusion. When there are multiple medications and there are already a person is taking psychotropic drugs, then a person is likely to develop delirium and substance abuse and not getting that substance anymore. Would anyone have thought constipation can cause delirium? It's a strange thing, but very common and something that we always tend to forget to look at. People with CNS pathology, which we've already mentioned, acute onset CNS pathology, organ failure, which results in chemical imbalance in the blood, the electrolytes and the uremia, all this can precipitate delirium. Infection is something, especially in our patients with palliative care, with malignancy, sometimes they may not have fever and their counts may be low, and we may miss infection or septicemia. And that is a very common cause. So we should look for constipation, infection, a bed sore. So these are some of the medications that I had mentioned. Diuretics dehydrate a patient and cause sodium-potassium imbalance and can cause delirium, right? So these are some of the things that we need to pay attention to. Another most important thing is, I mentioned bed sore. I hope you it registered with you. Another thing is the number of tubes you put in a patient, you're increasing their risk of developing delirium, like putting a Riles tube, a face mask, IV cannulas. People say he's going on pulling out the IV cannula, so we've tied their hands, urinary catheters, untreated pain. A person may not be able to tell you delirious, but the minute you start them on a painkiller, they become completely fine. So these are some of the things that you should remember and recognize. And some of the other precipitating factors would be hypoglycemia, hypothyroidism, sodium imbalance, hypercalcemia. I wonder whether palliative care emergencies is done or not done for you yet, but you will come to know about hypercalcemia. Of course, hypoxia, hypoperfusion, oxygen not reaching the brain. So how do you manage delirium? The first thing, these are the principles of managing any symptom. We try to correct the correctable. Constipation is correctable. Shifting a person who is used to using a pair of spectacles to see and does not have it anymore, just giving it to him, he will be able to see where he is and become more oriented. So there are certain simple things. Infection, you start an antibiotic, 24 to 48 hours, the patient would become more oriented. These some of the non-pharmacological methods, I think, yes. So we have to reorient the patient to place and time. Like my father-in-law, when he says we are in a train and which station does he have to get off, I have to tell him there is no kitchen in a train, there is no TV in a train. Then he realizes, oh yes, you're right. He forgets all over again, but giving them reorientation has made him, at least my father-in-law's dementia has dragged on for many years. I don't know whether that's a good thing or that's a bad thing, but giving these small pieces of information and orienting him to the scenario I found it very useful. So any information we give in small chunks, not long lectures. We take care of hydration, mobilization. Another very important thing is the presence of a clock, a calendar, or sunlight. So we can sometimes change the patient's position, their bed to near a window, so that when the sun rises in the morning, they know, okay, it's morning. That is subconscious, that is intuitive, that it is morning. Whereas sometimes the house is in the west, so the sun falls in the evening. There you are likely to have greater trouble. So that is another thing that we need to provide a stable environment. That is why if a patient is delirious in the hospital and if you decide to send them home, I'm sorry, what just happened? Yeah, so the minute they go back home, suddenly they are fine. because now they know this is my bed, this is my kitchen, or this is my stuff, and so they become oriented. We need to try and regulate the sleep-wake pattern, because like I said, it becomes altered. But using more medication to regulate the sleep-wake cycle we will be using psychotropic drugs, and they actually may sometimes worsen the situation rather than helping. So using non-pharmacological methods like stopping watching television at a particular time, getting the medication and having a timely, again, I can only give you my example from experience. My father-in-law gets his medications at 8 o'clock. They start kicking in. He gets dinner at 9, and by 9:30 he's in bed. So that's a regular pattern that has been established. So now, whether we give him the medicines on time or not, this is what naturally happens. So we have discussed spectacles and hearing aids. So we use physical restraints very often in the hospitals because we are worried that the patient may hurt nursing staff, their family member, any other patient, or a doctor. But it has been found that physical restraints actually worsen the delirium. So what is the alternative then? It is using chemical restraint, pharmacological treatment. When do you use it? Agitated delirium, which is what all of us identified, the definition of delirium that we've defined in the beginning. We all thought it was agitated delirium alone. So there you need pharmacological treatment. We'll come to the drugs too. You need to use chemical restraint because again, all these drugs are psychotropic drugs. They will have certain side effects. But when the person is danger to himself, I've heard of patients jumping off from the 5th floor of the hospital or something like that. When they're a danger to patients and staff, if they need treatment, if they need to go to get radiation, the patient has to be still. If they want if an MRI is required, the patient has to be still. So you have to use medications at that time. And when there is a lot of anxiety because of the hallucinations. These are some of the situations where you must use chemical restraint. Otherwise, we should try and use non-pharmacological methods more than pharmacological methods. So what drugs do we use for the treatment of delirium? So the most popular medication for use for delirium is haloperidol. And you can start from 0.5 milligram to 5 milligram as a single dose. And then you can keep repeating till the person becomes settled. You can repeat it every 2 hours. But if you're giving 5 milligram, the highest dose actually is 20 milligram per day. But I think Sunil will agree with me. I have not had to use a 20 milligram. This is probably Western data. My patients get controlled under 10 milligram of haloperidol. I may need to give a large bolus dose, a loading dose, and then maybe give 8th hourly or 12th hourly or as a continuous infusion to maintain the blood level. And that itself is enough. But haloperidol, the people are afraid in the ICU that it will cause QT interval changes, or people will say it will cause akathisia. Akathisia is a sense of feeling restlessness inside their body. They want to move all the time. And then you don't know whether the person is still delirious or is this akathisia because of haloperidol. Right? So that's another, and extrapyramidal symptoms. These are some of the side effects of haloperidol. Despite all this, when given in small doses, I have not as yet seen someone with any of these symptoms. In my last 18 to 20 years actually of practice of palliative care. But there are newer medications available, risperidone, olanzapine, quetiapine. I would suggest that if required, you refer the person to a specialist in this situation. The disadvantage of the other three medicines is that they can only be given orally, whereas haloperidol can be given orally, subcutaneously, and intravenously. So if the patient is agitated and you have to give him some medicine, to convince him to take it orally might be very difficult. He may say, "You're trying to kill me." But giving an injection might be easier. So that's the advantage of haloperidol over the others, though risperidone, olanzapine, and quetiapine have lesser side effects, better side effect profile. What about benzodiazepines? So when a person is agitated, we first think of, let's sedate. And we use lorazepam or midazolam and sedate the patient. But there has been a landmark study where they found that they gave patients haloperidol followed by lorazepam, and then they gave another arm of patients received just lorazepam. That study had to be stopped in the middle because patients who were receiving lorazepam were found to be getting worse. So lorazepam without the cover of haloperidol will make the delirium worse. Okay, so once you have given haloperidol, but the patient is still agitated, then you may use a benzodiazepine. Now lorazepam can be given orally, sublingually also, and intravenous also. But it has a long duration of action. When you start someone on this medication, you normally would give it 8 hourly. Whereas midazolam acts for 1 to 1.5 hours, and you can titrate the dose. You can stop it, you can increase it. I was taking a session somewhere else and people were feeling what benzodiazepines will cause respiratory depression. But I am an anesthetist, and I can tell you, using morphine and benzodiazepine, I used to be really scared about it. But after coming to palliative care, I found I'm giving patients midazolam 2 to 3 milligram per hour and nothing happens. So it is more our fear. For us also, we need to start the medications gradually, and we will gain confidence and become better clinicians. So this is palliative sedation. Sometimes when you try to find, is there something correctable for this patient? Does he have uncontrolled pain? Is he constipated? Is there an infection? Is there a bed sore? And you find that you can't identify any cause of pain, even hyponatremia. You can keep giving as much of hypertonic saline that you want, but when the body begins to shut down, the sodium will keep falling. So you cannot just indefinitely continue hypertonic saline forever for that patient. So it is invariably in retrospect that suddenly we find that the patient has passed away. And then we realize, okay, so this delirium, these changes in behavior were actually leading up to the patient's death. So what is palliative sedation? Palliative sedation is number one, you have excluded any correctable cause for the patient's delirium. You've tried to investigate and try to correct whatever could be corrected with ease. And if you didn't know, you have asked for help and guidance from someone else. You've left no stone unturned. You still need to keep the patient comfortable and the family also comfortable. That is when we use a combination of haloperidol or midazolam and sometimes morphine, especially if they were having pain or they had breathing difficulty. Then a combination of these three medications is the cocktail that is used most often. And but the dose of all these will change from person to person, right? If someone is on a high dose of morphine for their pain, they might require little amount of midazolam, not as high. But suppose someone has never received morphine and you want to start them for breathlessness, they might require a higher dose of midazolam or haloperidol. Okay, and all these three drugs can be mixed together and can be given to the subcutaneous route. I hope the subcutaneous route has been discussed or will be discussed subsequently, because it's one of the...
Not discussed, sir.
Okay, so would you like me to talk about it, or it will be covered by...
Yeah, a few lines.
Okay, so now the thing is, there are oncology patients who've been through in and out of the hospital for many months or years, and it is very difficult to find an IV line. And if you need to find an IV line, you have to sometimes give 5 to 6 pricks before you can find a good IV line. You can, if you use a 24 gauge cannula or a 22 gauge cannula, it will become blocked very fast. So then what do? How do you deliver the medicines if the patient is unconscious, he can't swallow? Are you going to put a Ryle's tube for that? For 24 hours, 48 hours, you don't know how much time. We do know if someone is dying. We have tried to see that everything that could be corrected has been done, and still the person is deteriorating. So now we know that the person does not have much time to live. So this needs to be communicated first to the family. And then we need to suggest that we can actually keep them comfortable using palliative sedation. And something, people take insulin injections on their own subcutaneously, right? So all you have to do is take a pinch of skin, pull it up, and slide a butterfly needle or a scalp vein under the skin, parallel to the skin. And it's not in a blood vessel, so no question of blood coming back. That little amount of air that is there in the plastic tubing will get absorbed in the subcutaneous tissue and then go into the blood and not cause embolism. And all these medications can be mixed and given either intermittently or as a continuous infusion, depending on where the patient is. In fact, through the subcutaneous route, we can also give normal saline. I have given up to 1.5 liters of normal saline because sodium is important, water is important in the end of life to prevent delirium. So depending again, if a person has a lung issue, I would probably give them only 700 ml insensible losses of normal saline. There is a small bump that gets formed. Patients don't normally find it uncomfortable, but if it is uncomfortable, we can stop the infusion for some time. Once the medication is absorbed from there, you can restart. So, but then why not intramuscular? The intramuscular, you'll have to prick again and again. You cannot keep a cannula intramuscularly, whereas subcutaneously you can put in a scalp vein. And the other thing is the blood supply to the skin and the subcutaneous area is better maintained towards end of life than the intramuscular area. So if you're giving some medication through the intramuscular route, you don't know whether it is actually reaching the target endpoint where you want the drug to be. So the other thing is, now when something like this starts happening, the families need to be supported. They have to be told that we are not looking at much time. They should probably call their other family members who are important to them. We need to tell them that this is a chemical imbalance in this in the mind that is happening, and the patient does not know or is not aware of what they're saying. So that that guilt that people may have, or the anger. We've been married for 50 years and we've gone through the difficult times together, and she doesn't want to see my face, was my grandfather's complaint. So, and there was nobody to explain this to us till I came to palliative care and learned about this. So I was in my first year of MBBS when this happened. So also, our medicine is becoming an area of super specialty. There may be things that we may miss in our identification. So asking a colleague for help, or having a multidisciplinary team meeting and sitting and discussing, this is the current issue. We are not able to get it under control. You have a multidisciplinary team meeting, and maybe someone will have a brilliant idea that, okay, this is happening. Or someone may say, yes, this is terminal delirium, so we should be sedating. We should be having the relevant talk with the family members about not sending to the ICU, the futility of ICU, the futility of CPR in this scenario. And our goal of treatment, we're still treating, but instead of treating the condition, now we are treating the symptom to prevent the suffering. So there you go. Now I stop. All right. So Sunil, that's from my side.
Okay, Charu, thank you. And we can take a few questions.
Yes, absolutely.
Anybody have any questions?
So, Savitri has written, is delirium only a sign of dying, or is it only a symptom that has to be managed? Well, definitely delirium is a symptom that has to be managed, but there are certain, how would I say, there are certain markers or certain red flags which give us an idea that the person does not have much time left now. So a person who has delirium will have another delirium episode. You've controlled one, they may come back with another delirious episode. So that might give us an indication that this person does not have much time left. Because delirium is caused in the background of all the complications, the dementia, the depression, the other things. There is an acute medical event that happens, and that's why delirium is an acute onset symptom. Right? So it could be infection. A person is neutropenic because their bone marrow has been infiltrated with the cancer cells. Whatever antibiotic you give them, the person is not likely to recover and may become delirious because of the infection. There, that gives us an idea that the patient probably does not have much time. But you shouldn't presume that all patients who are delirious are dying.
Sir, that's one question regarding what environmental modifications can be done to keep the patient comfortable at home for managing delirium.
Yes.
I have told about blog, so what else can be done?
Yes. So I think that's a very good question. I have recently moved to a new city, and the minute I moved to the new city, our COVID lockdown started. And it was January, February, and shopkeepers and medical representatives had not started giving out calendars and diaries for the year. And so I don't have a calendar of the year in my house. And invariably, I'm scratching my head whether, my God, this was just August. It suddenly becomes September. So, having a clock, having a calendar, telling them the day, the person that it's a Sunday, that's why everybody is at home today, and maybe rearranging the if there is space. Again, this it'll have constraints depending on the patient that you're seeing. There might be 5 people living in a single bedroom, or there may be a duplex house for 2 people. So the environment that can be done is, okay, we don't take them upstairs, we keep them so that they don't fall. Going upwards and downwards, it'll cause a lot of confusion. Moving their bed towards the window so that they can see the sunlight, which will keep their body circadian rhythm in tune with the day. So these are some of the things. And like I said, their earplugs and their, hearing aids and their spectacles. So if they have their spectacle, making an attempt to read the newspaper, they will see the date, they will know what is happening. So these are some of the things that should be done quite early on to delay or prevent. And one problem that happens in hospitals is the nurses' shift keeps changing. So the patient then tends to get disoriented that who's this now? Now who's this? Because we doctors are not in the habit of introducing ourselves to our patients. Does that answer your question?
Charu, I just want to add something to it.
Please, Sunil.
So, pharmacological management of delirium is very, very important. And one of the thing that need to be done is, if possible, place the patient near to a window where the patient can see the environment and see the daylight. So the patient will have a circadian rhythm when it is a day and when it is night. So I think this is one of the most important thing. And Charu has explained something on non-pharmacological management. In addition to that, wall clock, calendar, if the patient is usually wearing a glass or using some hearing aids, probably if in delirium, the family members will take it out and will not be allowed to wear it. But it is very important to wear this, otherwise the patient will have more agitation. And um, if you are able to show some photos which have taken in the past or albums, etc., and ask the patient when it was taken, what was the occasion, etc., etc., so that the reorientation to the time, place, person, etc., will come back. So and if the patient is walkable, you should allow the patient to walk with an assistant. So early mobilization is very important in delirium. So these are something which you can do non-pharmacologically if the patient is at home. I see there is one more question. How does one differentiate between akathisia as a side effect of haloperidol as opposed to symptoms of delirium? Charu, do you want me to answer?
Yeah, I said go ahead. You could go ahead. I will add anything if I.
So usually the people with akathisia, they find it very difficult to be calm. So they will be rock back and forth. They may walk, they cross and uncross their legs, grind or moan, something like that. So these are the common symptoms of akathisia. But if you look at delirium, the patient has uh, uh, they will not be attentive. But I think akathisia patients, even though they are restless, they will be able to focus what you are focus to you, and will give you the correct answer. But the people with the delirium, they will not focus, and you may not get correct answers also. There will be irrelevant speech which may not see in akathisia. uh, and other symptoms like um, hallucinations, delusion, etc. are there in delirium, which may not be there in akathisia. And the conscious level, it also fluctuates many times in delirium, but in akathisia it will be normal. So I think these are some differences by which you can differentiate between akathisia and delirium.
Just wanted to add one point. In situations where you're not sure what's happening, it is best to start with a small dose of drug and then titrate it upwards. Do you know what is the drug of choice for treating akathisia because of haloperidol? Anybody? A wild guess? How many people have seen EPS with metoclopramide? So akathisia and extrapyramidal effects happen because of dopaminergic receptors, and haloperidol and metoclopramide have a similar mechanism of action. So when people have EPS or akathisia, a person with metoclopramide will say that I am feeling very restless inside. I want to move. Like Sunil said, they will keep shaking their leg, not gently, but quite vigorously, as would be in panic. So that's the sign of akathisia. They will tell you they feel it inside, that restlessness, that need to move is what they're feeling. And the drug of choice is Phenargan. Phenargan is chlorpheniramine. I keep getting mixed up with these antihistaminics.
Promethazine, ma'am.
Promethazine. Thank you.
Yeah.
Yeah, I keep forgetting. Thank you very much.
So, Charu, shall we move on to patient story?
Yes, absolutely.
By Dr. Surajit. Dr. Surajit?
I'm muting myself.
Yeah, Charu.
Yeah, I'm ready. Hello.
Yes, Dr. Surajit, can you share your screen?
Yeah, I'm going to share it. So it is okay.
Yes, sir.
Okay. So I'm Dr. Surajit Giri. I'm basically an anesthesiologist and practicing anesthesia, critical care in ICU also, and little bit of palliative care in Sibsagar, which is around 400 kilometers east of Guwahati. My case is a 75-year-old male and who has a carcinoma of the right lung, and he has received palliative radiotherapy to lower back for the vertebral metastasis 5 days ago. And his presenting complaints were he has an abnormal agitated behavior since 2 days, mostly during the night. And during such episodes, he talks irrelevant things. And he has an attempts to get out of the bed and go out from the house. And other times, he looks fine and behaves absolutely normal. And if you go through the history of illnesses, his lower back pain, which was there, came down, but he spends most of the time in the bed because he was advised to restrict the weight bearing. And we have also talked to discuss about the pain control, and he said it was satisfactory. He was on morphine, he was on paracetamol, he was decadron, he was on bisacodyl, and he was on omeprazole. And when we found he was in well-beaten, which is around 58 kg, nutrition in him, he was totally conscious, oriented to time, place, and person. He is responding. The pallor, actress, etc. was absent. Dehydration was absent. Heart rate, blood pressure, everything was normal. We have ausculted the chest, and we found there was no crepitation, no rhonchi, etc. Means everything, every organ is functioning well. And we went further history of the patient, and we found that how he's spending his day-to-day activities in the home, how his family members are treating him, how much time the family members are spending with him. During communication with him, whether his family members are showing some frustration, loss of hope, etc., whether he is feeling hopelessness, whether he is spending most of the time alone, and whether he was most active with his legs before bedridden. So that we have tried to come through his history. And we have investigated his blood's profiles and all. We found all investigation was normal. Sodium, potassium was normal. There is no hypoxia and no hypercarbia. And sometimes the hypercarbia will causes restless behavior in the night, was also ruled out. We found these issues. Number one, a lot of psychological issues, spiritual issues was there. He has no quality time with Mr. X to talk, and he was, when he was young, he was a good football player. That is the most traumatic thing to him, because he's now in a bedridden position. Psychological aspect, what we have found from the history, he asks, why me? Had I done a sin in the past, whether it is a curse for my sin, I am alone. Nobody cares me. Nobody talks me. I am fear of paralysis. How can I do toileting? I am burdened to the family, and I am making my family poor. So whole day that he thinks this thing whenever he is in the bedridden position, and probably this may be the reason of this behavior. Yes, we talked to our psychiatrist. We discuss with him. We spend quality time, almost around half an hour to 45 minutes. We counsel him, and we try to solve these all issues: spiritual, loneliness, no companies, no one is carrying him, no one is there to talk, impending fear of paralysis, toileting. That all we have discussed and tried to give him solution. And these are the medication. These medication were given to the family members, not to the patient, ladies and gentlemen. We told out the family members that spending more time with the Mr. X is the only solution. Encourage him, remind him his old sweet memories. And we have advised them, if there is a kids in the home, to spend lot many time and play with him, and do not allow him to sleep alone. Someone from his family members should sleep with him. Compassionate care, and there should not be any discussion about negative issues. So this prescription was given to the family member. And to the patient, we have given the quetiapine 25 milligram at bedtime for 3 to 5 days, and then 12.5 milligram means half tablet at bedtime after 5 days. And then it is an actually atypical antipsychotic, and it was available in my town, and that is why we have started this tablet. And that was feedback we have got from the family members. And Mr. X was comfortable till 28 days. 29 day again, he has an agitated and restless behavior. He was admitted to another hospital, admitted directly to the ICU, and he was tied to the bed for extreme restlessness. He was so much of restlessness that healthcare worker tied him to the bed. Heavy sedation, including anesthetic like propofol, etc., was administered to calm down his agitated behavior. And to protect the airway, trachea had to be intubated, and on 30th day early morning he died. So main concern, ladies and gentlemen, are we addressing the delirium on the right direction? Where I was wrong in this case, what I have missed in this case, can we prevent this happening, and what could be done better for Mr. X or such patient? So in summary, he is a 75-year-old male, CA right lung, hyperactive delirium, failed to address probably. I should say it like this, that I have failed to address it properly and dying in an undignified manner. So discussion points, these are, there is psychosocial issues, the spiritual issues, loneliness, and fear of impending vegetative state. Thank you very much. Over to you.
Thank you, Dr. Surajit. So I think you have reflected on your patient, and I also think that you might have some answers in your mind, but let's ask others about the issues that you have raised. What are the psychosocial, spiritual issues and loneliness, how it can be managed? Any comments?
I think the history has been taken very well. I think when I speak, something's good. Can you hear me now?
Yes, we can hear you.
Okay, is that better? I don't know, there's an echo disturbance coming from my side, I think. So I think the history of the patient has been taken very well. That's great, Dr. Surajit. You have spent time psychosocial, you spent time with the family, you have brought in specialists to give counseling. But there are a couple of questions that I have to ask.
Yeah.
Can you tell me why you started him on quetiapine?
Madam, this is actually we are using regularly, and we are very much used to it, quetiapine.
For what? Indication of quetiapine is?
Because of his restless behavior in the night.
Okay.
So we have hyperactive delirium.
Okay. Sunil, shall I continue?
Yes.
Sunil, can I continue?
Yes.
Okay, so I think if we are looking at just delirium, there are a couple of things that I would want to first note. One, the patient is on bed rest. He's getting morphine. He's getting Dexona.
Exactly.
And when he is at bed rest, does he require the morphine, or does he require morphine only when he's moving?
No, even in the bed rest, because already metastasis was there in the vertebra, so there is a pain also, but it is well controlled by the morphine. Yeah.
So no, this is there is a specific thing that I'm trying to bring out here, which is when the patient came to you, he was in severe pain. You started him on morphine, and you got his pain well under control.
No, madam. No, madam. He was already on morphine, and the pain was adequately controlled. Not in pain.
That's fine. I understand. So the pain was well under control, but now you need to know that when the patient is on any patient, I'm not talking specifically of this one, but if the patient is on bed rest, his pain is well controlled, but when he's walking around also his pain is well controlled, then when he goes to his bed to rest, then the morphine requirement actually should come down.
Okay.
Because the pain is being relieved by other things also. For example, the bed rest, it may be Dexona. So whenever some patient is on morphine and something definitive is being done for the patient's pain, you're using either some non-pharmacological method or you're using palliative radiotherapy, the cause of the pain may come down, then the morphine could be the drug that is causing the delirium and will have to be retitrated.
Okay.
A second thing again about the drug here, I would like to say Dexona, our body secretes it in the morning according to our circadian rhythm. But when we prescribe Dexona, we invariably give it 3 times a day. And Dexona is notorious for causing sleeplessness and psychosis.
Exactly.
So these are 2 things that I wanted to mention about drugs, because we keep prescribing medications. We forget to cut down medications when they are no longer needed.
Madam, the Dexona was given to decrease the edema, and it
Yeah.
was in OD that is in the morning hours, not
Okay.
PD. And we have seen
I'm
also.
sure you were doing this. I just mentioned it for the rest of the group. You know that I have seen neurosurgeons give it 3 times a day, and then they say that the patient doesn't sleep at night and becomes agitated. So this is something about Dexona that all of us should know. Perhaps, I mean, you were probably giving him with the correct way that you have been taught, and how you have learned how much to give, what time to give, but not everybody knows that. So that is something that we need to think about. Sometimes people undergo surgery. First few days, they may require medication for post-operative pain. After that, the cause of the pain has been removed. So the drugs need to be tapered down. Otherwise, they will start causing delirium.
Exactly, madam.
That's my contribution. Would anyone else like to add something?
So, in case of delirium, there are factors and precipitative factors. So, risk factors are baseline factors which is in the patient. And there are some precipitating factors. If you look at this patient, the risk factors are advanced age, advanced malignancy. Both are risk factors. And as Charu told, I see that 2 precipitating factors. One is opioids and the other is steroid. But this patient, how was the retention, and especially as he's an elderly. Rajlakshmi, am I not audible?
So now you are audible.
Okay. So I don't know. Let me see. Have you seen now?
I think everyone should be muted except perhaps Dr. Sunil.
Have you seen now, Rajlakshmi?
It is perfect now, sir. You can continue.
Okay. What I told was there are some risk factors for delirium, and mostly the risk factors are advanced stage, advanced malignancy, and history of previous delirium or dementia. These are some risk factors, and in addition, when there are something which can precipitate delirium, and there are many factors which can precipitate delirium, and in this patient's case, we can see that opioids, steroids, and probably I'm not sure, but opioids can cause constipation, and it can also cause urinary hesitancy. In addition to his advanced stage and benign prostatic hypertrophy, he might have urinary retention or hesitancy, which all can precipitate delirium. But I'm sure Dr. Surajit might have managed it very well. But this is how you have to look at delirium and its precipitating factors. And infection is one of thing which can cause delirium or precipitate delirium. And unrelieved pain is also another precipitating factor. But I understand that these were all normal. Pain was controlled. There were no infection, etc. So maybe because mostly he was in the bed, and maybe that's also another factor which can precipitate delirium. And even wrinkles in the bed sheet can cause delirium. Uh, these are something which I wanted to add to this.
I think that is a very important point that Dr. Sunil has added, that a person who's continuously or mainly on bed rest, even the wrinkles in the bed sheet can produce delirium. And how you have not mentioned that the patient is paraplegic, but just in case you have any other patient who is paraplegic, uh, there is a high, it's an, again, they have a neurological component of illness. So not sensing your lower legs, but having, I mean, not being able to move your lower legs, but being able to feel phantom limb pain can cause, can be a precipitating factor for delirium.
Yeah, exactly. And this patient is actually not paralyzed, madam, but he is
Yeah.
in the impending fear of paralysis.
Yeah, I noted that you said that, but I just wanted to say that paraplegia can also be like I had mentioned, stroke and other any neurological condition, and any medication which interferes with your or any psychotropic medication which interferes with your brain, they are all capable of causing delirium. And there are two things which are not directly related to delirium, but something which is which I hear very often and which tends to disturb me a little is that you mentioned that you had told the family members that nobody should talk about any negative issue.
Exactly, ma'am.
Sunil, do you have any opinion on this?
Yeah, this is something which we need to be careful, because if somebody has a problem, all the family members will go and talk to the patient, to the doctor and other social worker, etc. And the patient will be concentrating on that, and they may think that, okay, something is happening and they are not telling me, this must be very serious, etc., etc. So they have their own fears in the mind, and because of that itself, the chance of restlessness would be very more. And moreover, we have had about ethics, and patient's autonomy is important. So I think we need to talk to the family members and make them aware that it is the patient need to understand about his condition, because he is already 75. Uh, so with an advanced malignancy, he is going to die maybe in the coming months. But then he has to finish all his business. Even it may not be big things, but maybe something like he want to eat a laddu because he was diabetic, and family was not allowing to take that. So there are many things which says us that the patient should be talked to, and should give realistic hope to the patient. But nobody should talk negative things. Is not something which we usually do in palliative care. We should talk to the patient and find out his concerns, and then we have to and then only we can help the patient. Otherwise we may not be able to communicate to him in the best manner. Charu?
Yes, I was just, I completely agree with you, Sunil. And, we first need to find out, even I think if you've already had your communication skills session, you would have known that even if you don't tell the patient the bad news, the patient's body will tell them what is happening. So, not talking about any negative issues. There may be things that the patient actually wants to talk about to somebody. And we are all trying to it's what we call the elephant in the room. We are trying not to talk to him. Yes, serious discussions about the future need to be done out of the earshot of the patient if the patient does not want to know. But if the patient wants to know, then it is better to, the patient may feel a little depressed for some time, but will understand and accept what is happening. So, not talking about negative issues or diverting the topic to something else can cause more frustration in the patient. The patient may himself feel that last week I was better, this week I'm not. What will happen to me next week? So the patient's body may tell him things which we are not telling him verbally. So it's important to know what the patient knows and what his concerns are. Does he have any questions? When we talk about counseling, it seems like, the image that comes to my mind is a gift box, nicely ribbon has been put, and we are gifting it to the patient. It's not that. It is a therapeutic communication. You need to ask the patient what concerns him most, what bothers him most, what has helped him in the past regarding these things. So counseling is a term I'm not very comfortable with. I prefer to call it therapeutic communication, because sometimes just talking to someone about what's happening to them makes a person feel emotionally, psychologically better.
So there were some questions at the end. I think we have partially covered those psychosocial, spiritual issues, which I think has to be found out by, as Charu told, by therapeutic listening. And loneliness, we need to talk to the patient's family.
Yes.
And find out the problems, why he is alone and why he is feeling lonely. First of all, talk to the patient, and then talk to the patient family, and give him some companionship. Maybe if the family is not is unable to do that, maybe he's able to do that. I think, I think we need to talk to the family and then come to a solution. And fear of impending vegetative state, this is also we have to ask the patient why he is thinking like that. Dr. Surajit, is there do you think this patient will be come to a vegetative state?
Hello? Maybe because there is an extensive metastasis and he may land up in paralysis.
Okay. So spine mets or brain mets?
Spine mets.
Okay. Okay, so it is better to tell him that okay, if you suspect or if you have seen in the MRI that okay, this patient has probably his spine is destroyed so much. So if not destroyed so much, then you can also tell them, okay, probably what you are thinking is not correct. There is a chance, but if you take some precautions like uh, don't wait there and things like that, then he may not go into such vegetative state. And if something happens, we will help you with some medications like steroids and radiotherapy. And it is important to find out the weakness very early. And if he has back pain, then definitely we will go on for radiotherapy, not waiting for the weakness to develop. So that we can probably we will be able to the power will be able to restore, or he will not go in for paralysis.
It's very, uncertainty can be a very distressing feeling. And as Sunil said, if someone has a metastasis in his vertebral column, if we give them indications that, you know, if you start developing a sensory impairment, if you feel that something is walking on your leg, that then you should hurry and come to the hospital. So that gives the patient a sense of control, some knowledge and what to do. That gives, so the uncertainty that comes, I believe it is very common for most of our patients, that's the you know, everyone, all of us tends to think of the worst thing that is going to happen. Currently, all of us, I think somewhere in everyone's back of mind, there is this feeling, what if I end up getting COVID? So, you know, that uncertainty can cause a lot of anxiety and panic, and more separation and loneliness from the family. So honesty is important.
Yeah, thank you, Charu. I think we have to wind up the session.
Absolutely.
So thank
Overshot.
you, Charu, for a wonderful session on delirium. And thank you, Dr. Surajit, for coming up with a good patient story and discussion points. And thank you all for your active participation. We'll see you on next Tuesday. Rajlashmi, it's over to you.
Thank you, sir. Thank you, Dr. Charu and Dr. Surajit, for that excellent interactive session. Thank you all for joining in. So there is a change in sessions for next week. Next Tuesday, we'll be having a session on organizing palliative care services, followed by the session on palliative care emergencies on Thursday. It's due to the availability of faculty on those Tuesdays. Thank you all. We'll see you next Tuesday. Bye.
Thank you very much.
Thank you.
Bye, Charu.
Bye, Sunil. Just say